What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be doing an introduction to respiratory infections. So, just as an overview, first we're going to be talking about epiglottitis, which occurs about here. Then we're going to talk about laryngotracheobronchitis, which happens just underneath that, about here. Then we're going to be talking about bronchiolitis, which occurs in the bronchioles over here. And then finally, in the alveoli and in the lung interstitium, we're going to be talking about pneumonia and lung abscesses. Alright, so the first infection that we're going to talk about is epiglottitis. And as the name implies, it is the inflammation of the epiglottis, and it is classically caused by Haemophilus influenzae type B. And it's just an important note that with the modern day Haemophilus influenzae type B vaccine, this infection is far less common, and furthermore, it can also be caused by other bugs such as Streptococcus pyogenes and Streptococcus pneumoniae. Okay, so epiglottitis classically presents as a child with a very high fever. Especially in a boards question, they can have a fever as high as 103 degrees Fahrenheit. And the rest of the symptoms and presentation really just has to do with the fact that there's an inflamed epiglottis. If we just take a look at this diagram right here, the epiglottis is right here, and when it becomes inflamed, it really starts to take up a lot of room in the throat. So this can cause things like drooling, dysphagia, and inspiratory stridor. If the epiglottis is so inflamed that it's blocking passage to the esophagus, this can present as dysphagia, and also oral secretions can start to pool up, and that can present as drooling. And furthermore, as air is inspired and it makes its way through this very narrowed airway that the inflamed epiglottis is making, it's going to make a very loud, harsh sound called inspiratory stridor. Next, these children classically assume a tripod position, which is where the child is leaning forward with their hands on their knees, their head is tilted back with their mouth open, and this allows them to breathe a little easier. And lastly, on lateral neck x-ray, we can see something called the thumb sign. So if we take a look at this x-ray right over here, we can see the epiglottis is right here, and it's very inflamed and looks thick like a thumb. Okay, the next condition that we're going to talk about is laryngotracheobronchitis, also called croup. So also, as the name suggests, it's the inflammation of the larynx, the trachea, and the bronchi, and it's usually caused by the para-influenza virus. And so laryngotracheobronchitis mainly affects the subglottic area right here, and the trachea and the bronchi right here. And laryngotracheobronchitis classically presents as a child with fever and a barking seal-like cough. This is a fairly specific description of the cough for this condition. And this condition also has inspiratory stridor, and that's because these upper airways here are inflamed and narrowed, and so as air makes its way through this narrowed passageway, it's going to make a very loud, harsh sound heard as inspiratory stridor. And lastly, because of the subglottic narrowing, on frontal neck x-ray, we can see something called the steeple sign. So if we just take a look at this x-ray right here, we can see that there's a bit of a steeple which represents subglottic narrowing. And so a lot of questions try to get you to differentiate between epiglottitis and laryngotracheobronchitis because they both present with a child that has fever and inspiratory stridor. However, if they tell you that the condition was diagnosed using a frontal neck x-ray, then that means they're probably talking about laryngotracheobronchitis as they imaged that steeple sign. However, if they told you that the condition was diagnosed using a lateral neck x-ray, that means they're probably talking about epiglottitis as they imaged that thumb sign. Okay, and the next condition that we're going to talk about is bronchiolitis. And again, as the name implies, it is the inflammation of the bronchioles, and it's usually caused by RSV or respiratory syncytial virus. And so if we just take a look at our diagram right here, we're mostly going to be seeing inflammation of the bronchioles in this condition. So bronchiolitis classically presents in a very young child, usually less than 2 years old, and they have fever and wheezing. And recall that if we have narrowed and inflamed bronchioles, then we're going to get a wheezing sound as air is expired through those lower narrowed passages. Okay, so the next infection that we're going to talk about is pneumonia. So pneumonia is the infection of lung tissue, and it classically presents as fever and a cough, and the cough may have mucus or it may not have mucus. If the cough has mucus, then we call it a productive cough, which is usually seen in the lobar and bronchopneumonias, which we'll talk about in just a minute. And if there's no mucus, then we call that a non-productive cough, and that's seen in interstitial pneumonia, which we're going to talk about in just a minute as well. So the classical physical exam findings that we're going to find in pneumonia is increased fremitus and dullness to percussion, and that's due to the consolidation of the lungs. And we're also going to see rales and bronchial breath sounds. And for the pneumonias that have a productive cough or a cough that has mucus in it, we're going to see that a lot of the inflammation is driven by neutrophils in these types of pneumonia. And a fact that board examiners like to go after sometimes is that the sputum gets its yellow-green color from the pigmented myeloperoxidase enzyme found in neutrophils. So the disease process of pneumonia will classically follow one of three patterns. The first pattern is called lobar pneumonia, or sometimes referred to as typical pneumonia, and this is kind of the classic pneumonia. So as the name suggests, in lobar pneumonia, we have the infection of one entire lobe of the lungs. And what this infection is going to look like is intra-alveolar exudates, or there's going to be an exudate within the alveoli, like in this picture right here, we can see the alveoli and we can see all the exudate within them. And so most of the alveoli within one lobe of the lung is going to have these intra-alveolar exudates within it, and that's called lobe consolidation. And the most classic microbe that causes lobar pneumonia is Streptococcus pneumoniae. And lobar pneumonia classically follows a 4-step disease process. The first step in this process is called congestion, and this happens within the first 2 days of the infection. So what happens in congestion is there's a microbe that's introduced into the alveoli, like strep pneumo just enters the alveoli, and it's going to cause alveolar macrophages to release certain cytokines, and those cytokines are going to cause vasodilation of the surrounding vessels. And that vasodilation is going to allow for some fluid to leak into the alveoli, and that fluid mixing with the bacteria is going to create a bacterial exudate. And we really call this the congestion phase because the introduction of the microbe into the lungs is going to cause the nearby vessels to vasodilate and become congested. So the next phase is called red hepatization, and this occurs at 2 to 4 days during the infection. And it's called hepatization because all of that inflammation and fluid is causing the lungs to firm up and resemble more like the liver. And it's called red hepatization because that exudate that's collecting in the alveoli is now beginning to include red blood cells, which is giving it that red appearance, and the exudate is also starting to include neutrophils and fibrin, and the neutrophils, like we said, are really driving the inflammation at this point. The third phase is called gray hepatization, and that occurs at about 4 to 6 days during the infection. At this phase, that red color of the lungs starts to become a little bit more gray as the red blood cells become lysed and degraded within the alveoli. The last phase would be the resolution of the pneumonia, and this is where we're going to get the recruitment of new macrophages that enter into the alveoli and replace the alveolar neutrophils, and these new macrophages are really going to digest and clear out that fibrinous exudate present in the alveoli. And furthermore, all of that inflammation that occurred most likely damaged the alveoli, and recall that the predominant cell in the alveoli is the type 1 pneumocytes, and so we're going to get type 2 pneumocyte hyperplasia because recall type 2 pneumocytes were involved in the repair process because they can regenerate and give rise to new type 1 pneumocytes. Okay, so now if we just take a look at this x-ray image here, so we can see in this chest x-ray of the lungs here, we have a lower lobe pneumonia. We can see this lower lobe right here is opaque and infected. Okay, so the next pattern of pneumonia that we're going to talk about is bronchopneumonia. And bronchopneumonia is very similar to lobar pneumonia, except it's a little more limited to just infection of the bronchioles and nearby alveoli in one lobe, and so it's a little more patchy this way. It's just infection of these bronchioles and nearby alveoli, and so on x-ray it's going to show more as patchy opacities in one lobe. And a microbe that commonly causes bronchopneumonia is Staph aureus. And the last pattern of pneumonia is interstitial pneumonia, also sometimes referred to as atypical pneumonia. And in this pneumonia, we have infection of the interstitium, or the space or tissues between the alveoli. So if we just take a look at the diagrams in the bottom left here, we're going to have inflammation between the alveoli and within the alveolar walls. And so this picture is what the histology is going to look like. We're going to see the cross-section of the alveoli and all of these inflammatory cells and lymphocytes between the alveoli. And this type of infection is more diffuse and widespread than the lobar and bronchopneumonias, and so we're going to see patchy, diffuse opacities on x-ray. And furthermore, the classic lobar pneumonia pneumonia usually is caused by bacteria such as strep pneumo, whereas interstitial pneumonia usually has a viral cause, or it's caused by atypical bacteria such as Legionella and Mycoplasma. And interstitial pneumonia usually isn't as severe as the other pneumonias, and so it usually has a more mild course compared to the other pneumonias. Alright, so now let's just take a look at the histology and x-ray of interstitial pneumonia. And so if we take a look at the histology image over here, this free space right here is the space inside of an alveoli, and over here is another alveoli, and this pink barrier that separates the two alveoli is an inflamed alveolar wall. And within this alveolar septum, we can see all of these inflammatory lymphocytes, which is characteristic of an interstitial pneumonia. And furthermore, in this x-ray image here, we can see all of these patchy diffuse opacities all over the lung, which again is characteristic of interstitial pneumonia. Okay, so moving on, we're going to be talking about aspiration pneumonia. And aspiration pneumonia isn't a pattern of pneumonia, so it's still going to follow one of the three patterns that we previously discussed, but this is more of a way of getting pneumonia. So in this condition, what we're doing is aspirating normal flora or normal microbes that live in the mouth or in the rest of the GI, and those microbes are entering the lungs and causing a pneumonia. And the classic microbes that cause aspiration pneumonia is aspirated oral flora anaerobes such as Bacteroides or Fusobacterium. Commonly, prior, these patients were either unconscious or having a seizure or alcoholic, where they're involuntarily vomiting or swallowing oral secretions into the lungs, and those microbes that live in the mouth are now colonizing and causing infection in the lungs. And furthermore, gram-negative enteric bacteria such as Klebsiella can also be aspirated into the lungs and cause aspiration pneumonia. Okay, lastly, we're going to finish up this video by talking about a lung abscess. So a lung abscess is a contained and localized pus collection in the lungs, and again, it's commonly caused by aspirating those oral flora anaerobes when we are unconscious or having a seizure or alcohol. And furthermore, just like all abscesses, it's also commonly caused by Staph aureus. And classically on x-ray, what we're going to see is an air fluid level, which represents a cavitation filled with pus. So if we just take a look at this x-ray image here, so we can see in this chest x-ray that this circle right here represents the abscess, the bottom opaqueness represents the pus collection, and the top black translucent area represents air. And this line at the top here represents the top layer of the pus, or the air fluid level, and this is a classic finding in a lung abscess on x-ray. And furthermore, all of that pus that's collected in the lungs is going to smell really bad, and so a classic finding is foul-smelling sputum in a lung abscess. And other signs and symptoms are classic of infection, such as fever, night sweats, and weight loss, and of course we can also see a cough. Alright, so let's just summarize a few key points on this slide here. So there were three patterns of pneumonia. There was lobar, bronchopneumonia, and interstitial. Of the three patterns, the lobar and the bronchopneumonia have exudate within the air spaces that can be coughed out, and so these have a productive cough, whereas interstitial pneumonia was infection and inflammation of these spaces between the airways, and so their cough does not contain any sputum, and it has a non-productive cough. And lastly, we can aspirate microbes from the GI into the lungs, and these are commonly going to be the oral flora anaerobes, and they're going to cause infection in the lungs in the form of aspiration pneumonia or a lung abscess. Alright, and that's all we got for our video on Introduction to Respiratory Infections.